Welcome back to the Rehab Radio. Let's learn about hemiballismus. Picture this. A patient's arm suddenly hurls outward with the force of a tennis, serve no warning, no intention. That's hemiballismus. But what exactly is it? Hemiballismus is a rare hyperkinetic movement disorder. Now, don't let that term intimidate you. Hyperkinetic means excessive movement, and here it's characterized by violent, involuntary, flinging motions on only one side of the body. Both proximal and distal muscles are fair game, and sometimes even the face gets involved. You may be asking, why so dramatic? Well, these aren't your everyday muscle spasms. The movements are continuous, large in amplitude, and random, impossible to predict or control. Imagine trying to sip coffee when your arm suddenly launches the cup across the room. It's as disruptive as you'd think. Hemiballismus is exceptionally rare, seen in just 1 to 2 people per million. So why do we care? Because recognizing it is crucial for physiotherapists who may be the first to spot its telltale signs during assessment. Now you might be thinking, isn't this just another form of chorea? Not quite. While hemichorea features more dance-like, flowing movements, hemiballismus is all about force, like a body trying to throw off its own limb. So, let's jump into what's really causing these ballistic outbursts. Spoiler. It all starts deep within the brain's motor circuitry. To unlock the mystery of hemiballismus, we have to travel beneath the brain's surface, to the basal ganglia. Think of the basal ganglia as a traffic control center for movement, coordinating signals so we move smoothly. Key members? The striatum, globus pallidus, subthalamic nucleus, and substantia nigra. Here's where it gets technical. The basal ganglia operate using 2 main pathways. The direct pathway boosts movement, the indirect pathway puts the brakes on. It's like having a gas pedal and a brake pedal for your muscles. Now, the subthalamic nucleus, STN, is our star for today. This tiny structure acts as an excitatory driver using glutamate, keeping the inhibitory globus pallidus interna, GPI active so unwanted movements stay in check. When the STN is damaged, say by a stroke, this check is lost, the GP slacks off and the thalamus gets overly excited. The result? Motor cortex goes into overdrive, causing those signature flinging movements. You might be wondering, just how abnormal is the brain's activity? Electrophysiological studies show the GPI in hemiballismus fires less about 30 Hz instead of normal higher rates. But more crucially, the pattern is erratic, like a drummer losing the beat, which seems to trigger the chaos in movement. So the next time you see a patient with sudden, wild arm movements, remember, it's not just muscles misbehaving, it's a broken circuit deep in the brain's motor highway. Let me tell you a story. Mrs. Lee, a 72-year-old with poorly controlled diabetes, woke up one morning with uncontrollable flinging of her right arm and leg. What happened? Her blood sugar had spiked, leading to a classic case of hemiballismus. This brings us to the causes. Understanding them is critical for effective rehabilitation. The most common culprit is vascular. Imagine a tiny stroke, an infarct in the subthalamic nucleus. That's enough to unleash ballistic movements. Hemorrhagic strokes, trauma, or even tumors in nearby brain regions can do the same. But here's a twist. Non-ketotic hyperglycemia, often in older adults with diabetes, is the second most common cause. In these patients, extremely high blood glucose acts like a toxin, temporarily disrupting basal ganglia function, especially in the putamen and caudate. That's why checking blood sugar in any new movement disorder is critical. Other, less common causes include infections such as HIV or tuberculosis, autoimmune diseases like lupus, metabolic disorders, certain medications, and even post-neurosurgical complications. So, whether it's a blood vessel gone rogue or a metabolic storm, always look for the root cause, because sometimes the best treatment is reversing what triggered the movements in the first place. How do you spot hemiballismus in a clinical setting? First, look for its calling card. Sudden, involuntary, large amplitude flinging movements on one side. But don't stop there. Think Sherlock Holmes with a stethoscope. It's time for a thorough neurological exam to confirm that this isn't a benign tremor or simple chorea. Now, what about labs? Always check blood glucose and hemoglobin A1C to catch hyperglycemia. These numbers can save a patient from unnecessary investigations. Don't forget inflammatory and autoimmune markers if the cause isn't clear. For imaging, CT scans might reveal a hyperdensity in the basal ganglia, especially in cases of hyperglycemia. But MRI is the gold standard. Its high sensitivity can spot even the smallest subthalamic lesions. Technical term alert: T1 hyperintensity in the putamen or caudate on MRI often points to non-ketotic hyperglycemic hemiballismus. Now you might ask, what if the scans are normal? Early in the disease, that's possible. Always correlate clinical and radiological findings for accuracy. In summary, diagnosing hemiballismus is like piecing together a puzzle. History, exam, labs, and imaging all bring the full picture into focus. Here's where you future physiotherapists step onto the stage. Once the medical team controls the root cause and tames the wildest movements, rehabilitation becomes essential for restoring function and independence. Start with assessment. Document movement, frequency, and amplitude, measure muscle strength and range of motion, and evaluate areas activities of daily living. Safety is non-negotiable, as these movements can be forceful enough to cause injury. What about treatment? Begin with motor control training. Graded movement exercises help patients regain voluntary command over their limbs. Weight-bearing activities give proprioceptive feedback, which can dampen the severity of involuntary movements. Proximal stabilization, especially at the shoulders and hips, is key for reducing fall risk. Don't forget functional strengthening, aerobic conditioning, and balance work. Use isometric exercises if dynamic movement proves too difficult. Incorporate occupational therapy for ADL, retraining, energy conservation, and home safety modifications. Now you may wonder, how soon should we start therapy? As soon as the most violent movements are controlled. Early, tailored rehab maximizes recovery and helps patients regain their confidence step by step, day by day. So, what's the outlook for hemiballismus? Here's the good news. Most patients improve dramatically with proper treatment. Vascular cases can resolve within weeks, while hyperglycemic hemiballismus often abates once blood sugar is controlled. But let's not overlook the long game. For stroke-related cases, the survival curve mirrors that of other strokes, about 85% at 6 months, dropping over the years. Recurrence risk? Substantial, especially if risk factors like diabetes aren't addressed. Functionally, the vast majority regain independence in ADLs, though a few may have lingering mild movements. That's why ongoing physiotherapy, patient education, and regular follow-ups matter so much. Here's a clinical pearl. Always check blood sugar in new onset movement disorders. Sometimes the cure is as simple as insulin. And never underestimate the power of a multidisciplinary approach. Combining medical, physio, and occupational therapy is often the winning formula. In closing, recognize hemiballismus early, act decisively, and empower your patients through education and rehab. That's how you'll make a difference.